I found it. Now it's recording. So 1 minute left. Okay, I start now. So, welcome everyone to this webinar. We will have an exciting discussion, and we will have first two very interesting presentations by Carl Rössler, neurosurgeon, and Ingmar Blümke, neuropathologist. And for you all to know, Carl and Ingmar has been working together long time in Erlangen. Now, since a couple of years, Carl has moved to Vienna, but Ingmar is still working in Erlangen. So please, Carl, I let you start your presentation, please.
Thank you very much, Bertil. It's a great pleasure for me to be with you today. And thank you again for the invitation. And I will share my screen for my presentation. Can you see it?
Sure, it looks great.
Okay. So when thinking about approaches depending on pathology, I remembered this paper from Ingmar. The special thing about this paper is that it is a summary of nearly 10,000 patients of surgical specimens, and what you see in this collection is that more than 50% of all specimens have only 3 diagnoses. That is hippocampal sclerosis, ganglioma, and focal cortical dysplasia. And this, how can I go ahead? Okay. This means that most of the pathologies we are operating on are focal pathologies. And I have done this the summary slide for today. There are 3 factors we have to talk about. The first one, of course, is what kind of pathology do we suspect from our images and so on. And there we have lesional and non-lesional pathologies. And in the lesional ones, we deal with focal pathologies and with global pathologies. And as you have seen, most of them are focal. And if we have focal ones, we are thinking about, are they eloquent or are they non-eloquent? And these simple facts determine what kind of surgical strategies we choose. Is it a resection, a standard one, or block resection, tailored resection? Is it a disconnection or stimulation? Or is it a lesioning, like using thermolit focused ultrasound or gamma knife? And the third point I wanted to raise is the tools. What kind of tools do we use, especially when dealing with focal eloquent pathologies? And as you see, we have a number of tools: functional imaging, invasive monitoring, awake craniotomy, neuronavigation, and even interoperative MRI. But as you suspect, tools don't necessarily make us to better neurosurgeons. So we have mainly to rely on the anatomical basis, on the surgical anatomy. And I think most of you have now in mind the Roton Atlas or other atlases. What I wanted to show you is this atlas. It's a an atlas dealing with the temporal lobe, especially with the temporal lobe, and it is from Josef Klinger, who was a surgical anatomical preparator in Basel in the middle of the 20th century, and he did these wonderful drawings. And this is not available at the moment, but I have it as a PDF, and everyone who wants to have it can write me an email, and I will send it to you. The first point I want to focus is a technical one, the so-called en bloc resection technique. If you look into a standard epilepsy surgery textbook, like this from André Olivier, you will see there is a lot done with the CUSA. I personally don't use the CUSA in epilepsy surgery. I use it in firm schwannomas or meningiomas because the CUSA is the enemy of the neuropathologist, and it converts the tissue into mud. And if you take only small biopsies, you won't get really a proper diagnosis. But how would you resect without taking the CUSA? Best thing is to use this en bloc resection technique, which means that you subperly work around the pathology and remove the specimen as a block, so that the neuropathologist can investigate the whole area of interest. And this not only increases the chance of radical resection in our types of pathologies, focal pathologies, but it also increases, of course, the chance of becoming seizure-free. And this is a paper also from Ingmar, and in this one it is nicely shown how this works. And I suppose he will show us this later, so that I only can give you these pictures from these en bloc specimen, even in MRI negative specimen, where you can resect the specimen and investigate, for example, the electrode tract. And this is my only video in the presentation. It is an en bloc resection of a left hippocampus in a patient with HS. And as you see, it's a really huge specimen, and I think we all have to be able technically to remove such a large specimen, hippocampus and parahippocampal gyrus en bloc, to allow the neuropathologist to get these fantastic pictures of the type of hippocampal sclerosis, not only to allow to do the diagnosis of sclerosis, but also to subcategorize the type, and by this way to give the patient an estimation of his prognosis. And in Erlangen, we did this also with a large MRI negative specimen, where we did invasive monitoring with depth electrodes before. And so Ingmar had the chance to find maybe also a subtle pathology, and also to correlate these pathological images and the dysmorphic neurons and balloon cells, especially in this FCD type 2B, with electrical findings from the EEG. Another pathology which I want to remember is these temporal encephalocele. We had a series of 10 patients in Erlangen, and 75 of them get seizure-free only by resecting the encephalophyll without any further part of the temporal lobe. And by doing this en bloc, we had the chance also to investigate these prolapse of the brain and to find the origin of the epilepsy, especially in this chaotic tissue of the encephalophyll and this loss of the regular cortical architecture, with you won't have the chance if you don't do this en bloc resection. The second point which I wanted to discuss is imaging and interoperative tools. Of course, if you do these large en bloc resections, you have to know where the functional areas are, and so you have to have a good cooperation and with your neuroradiologist to get him done these functional cortical and tract anatomical images, which we are normally use in our navigation systems to segment either the functional area and also the lesion, and project it on to the cortical surface of the during the surgery to find the pathology and also to spare the functional area. And as you see, this was our first robotic-driven microscope in Vienna, where we could introduce these contours in the eyepiece of the microscope. It is more than 25 years. It was more than 25 years ago, and since then we use every information we get during surgery by including it into the eyepiece of the microscope. And at the moment, we also have this two-room concept of an intraoperative MR suite combined with a neurosurgical operating suite. And we also can use monitoring by using special wires, and also can use intraoperative electrocorticography in this OR. But now I will give you a few examples and show you how these strategies can be used. The first case I wanted to show is a case where we normally don't use invasive monitoring. It is the case of a 20-year-old male who had refractory focal motor seizures for 4 years, and we could see these suspicious focal cortical dysplasia in the premotor, in the precentral area, and this blurring of the sulcus in the depths, and also this brightening in the VoxerBased morphometry. And we included this information, functional information, and also lesion information into the microscope. And we, even at the beginning of the surgery, before doing skin incision, we used this to mark the skin and to plan the craniotomy. And during surgery, we resected this lesion, and we also did this intraoperative MR imaging and correlated it with the pre-planned contours of the lesion. And indeed, it turned out to be a FCD2B, and this kind of resection was enough to get this patient seizure-free. He is still seizure-free. And the concept for focal eloquent pathologies in our hands is to do this multimodal imaging, to include this in the navigated surgery, and to be sure during resection to have resected it by performing intraoperative MR imaging. And we had a series of such patients published a few years ago, and we found it really quite useful. And here's this example of a DNet where during imaging we had to do a second step surgery because there was considerable tumor tissue left, which we didn't get during surgery, which we didn't find, or we didn't have the impression that there's really tumor left. In MRI negative cases, of course, every one of us uses these kind of invasives. You can see this was a case from 2012 with grid and strip electrodes. This is a recent case. We only use depth electrodes at the moment, or nearly exclusively depth electrodes because of the tenfold less complications. And in the OR, we also use this mini robot for invasive to get these depth electrodes into place. And despite that, we are sometimes we are obliged to do these large resections. And in Elearning, to avoid large resections, we always did MEGs before surgery in MRI negative cases, and we also included in 60% of patients we found focal areas of MEG activity, and we included into the resection. And we found that when we have resected the MEG area, the MEG spot, the patient had a much better seizure outcome at the end. A second case I wanted to show is one with invasive monitoring. It's a 42-year-old male who had, from the clinical point of view, a suspicious insular epilepsy for many years. And one of the insular electrodes, we always do two insular electrodes, one from frontal and one from posterior, and we found this continuously spiking area at the frontal electrode, and by using this contour guided navigation, we resected that area. And also in this case there was the diagnosis of an FCD2B, and the patient also gets seizure free. The tailored lesionectomy without invasive monitoring and intraoperative electrocorticography, it is most used by us in these cases of gangliogliomas. This was a young patient with a left temporal ganglioglioma, and in these cases we do a greater resection than the lesion, a widened lesionectomy, tailored resection, because these gangliogliomas, of course, Ingmar would show it, they superiorly spread, and if you miss that, then the patient won't be seizure free. Also with contour guidance and intraoperative MR, we could manage to resect it. And the fourth case, it is a tailored lesionectomy with also invasive extraoperative monitoring. We implanted, in this case, grid and strip electrodes. This was this kind of pathology, parietal lobe epilepsy in a young patient, but it was not typically from the clinical aspect. It was not, we were not sure that the epilepsy came from the lesion alone, and so we decided to implant this grid and the strips around. And what we found was a significant larger resection area due to the invasive monitoring, as the brown colored lesion was. And so we also used the grids intraoperatively for stimulation and mapped the motor cortex, and we used the intraoperative MRI for being sure that we had resected the pre-planned target area, also these kind of cortical area in the posterior part of the lesion. And this patient also became seizure-free and is still seizure-free. I think it is now 7 or 8 years. It was in Erlangen. And yeah, and the fourth point I wanted to emphasize is LIT and biopsy for pathological diagnosis. We have a series of LIT in tuberous sclerosis children. And of course, in these children, we do invasive monitoring. We try to map the active tubers in the PET imaging. And then we do invasive monitoring and do the LIT only for the active tubers. But in these cases, of course, you need not to have any biopsies because the lesions are well known in these children. But what to do in that patients? This is a young patient with a temporal lobe epilepsy where we did this AHE LIT. In this case, in such cases, we are always afraid to induce hemorrhages by doing biopsies, even small ones, and we are afraid that the LIT won't work. And so in these cases, we avoid to do biopsies, but we are not sure if this is really a state of the art. We can discuss about it. And as a conclusion, I think we have to have a close cooperation with the neuropathologist. I think I have shown that, and Ingmar will also show that in the upcoming presentation. But I think MRI negative cases and correlation with preoperative images and amount of tissue resected, resection borders, and so on. This question is, I think, best addressed by using this sub-BL or block resection technique I introduced at the beginning of my presentation. And I think by using this, you have much tissue preserved, and you get the chance for your patient that he gets an appropriate diagnosis, and you also have enough tissue for basic research, which also is one major point at the university clinics. So thank you very much.
Thank you so much, Carl. And please, Carl, stop sharing your screen. And now we welcome you, Ingmar, for your presentation. And then we take the discussion after Ingmar's presentation.
Oh, okay. So welcome everybody. It's a pleasure to be here with you. Thanks for the kind invitation. And yes, we probably will have our discussion of both presentations afterwards. So let me just see if I can share my screen and then get this big. Okay, so you should see my screen.
Thank you.
Wonderful. And I will have here my pointer, and yeah, I have nothing to disclose, and I was asked to address the interaction, right, between the neurosurgeons and the neuropathologists, and I'm very happy that Carl already mentioned most of the points here. So I will follow up on this and give you some examples, and I'm very happy to take questions or to discuss with you afterwards. So this is kind of the different points I wanted to highlight here, and as you will hear in a minute or so, I strongly believe in a close interdisciplinary cooperation with with the neurosurgeon, with the epileptologist, with the neuroradiologist, the neuropsychologist. This is for me a very important take-home message, that epilepsy surgery doesn't work on its own. Just you don't do just the surgery. This is a lot of people have put their efforts into characterizing the epilepsy, the seizure onset, then the lesion, and as a surgeon, you are very you do a different job, to my understanding. It's not that you just remove the lesion. You do a rather functional surgery, right? The aim of the surgery is to get the patient seizure free and not lesion free. And so the pathology here, although at the end of the food chain, I think our cooperation should start early on, and that is already at the level of, let's say, the patient management conference. So this is what we do here in Erlangen. We always attend the patient management conferences, and the best thing is when we know up front what is planned, and that we can also give some hint. And as Carl mentioned, of course, we very much like en bloc resections, larger resections, so that we can identify the lesion, but also the surrounding tissues, so borders. And I mean, there are many examples I could raise, and maybe we can discuss some of them later together. But here, yeah, this is a nice picture. Basically, the drawings in A and B came from Jorge Gonzalez, who's also here with us today, from the Cleveland Clinic at that time. So that was really taken from the OR. So, and you see here that Jorge used the stapler to indicate the anterior posterior axis of the specimen. So that is important, that we know the anatomical localization once the specimen is out of that situation, because then we cut it, and at the end, at the microscopic level, it's very difficult to tell where the particular area was at the end in the brain, and this might be very important for you for some reason. And yeah, this is obviously the same thing that Carl already showed, the intraoperative MRI. So you have a very well characterized patient, a deep phenotyped patient in terms of the neurophysiology and the structural imaging, and then you may want us to give you feedback. What was the structural abnormality at the cellular level, or even at the molecular level? And this is, I think, what's going to happen even in the near future in terms of precision medicine developments, where we need this information. And this is exactly how it should be. And it starts, as I said, it starts before surgery. It starts at the level of the patient management conference, and then in the OR. And we stay in contact, so that everybody of that team knows exactly what's going to happen, and then we can give feedback. And this is the example that Carl already showed, where we have tried to co-register the whole specimen into the preoperative MRI here with all the grids and depth electrodes, and so we could localize. That this here is a trajectory of the intracerebral EEG, but we were also able to really identify the contact, so the level of which electrode contact is in which slab, and then bringing that back into the preoperative MRI. And that allows us then to study the neurophysiology signatures of this FCD, and here where you have these HFOs only where the neuron density was very high, and where the dysmorphic neuron density was very high, and the balloon cells usually do not play a big role in the abnormal EEG signaling. And another study from a similar time period at that time with the colleagues from the Cleveland Clinic did something very similar. Here they are all the intracerebral EEGs or stereo EEGs from patients with bottom of sulcus FCD type 2. And here we wanted to see the genetic signature of the FCD in very close relation to the neurophysiological trace. And you see here, this is the patch, the microdissection, where we took the tissue right out of the FCD2 and could prove there an mTOR mutation. Good. So this is the whole concept, and I'm very happy that I can talk here about my experience with that, and I think it should be this way in every epilepsy surgery center, so that you have this interdisciplinary group, and the pathologist should be part of that. And the other thing is that when we have an active epilepsy surgery center and we are collecting tissues, that we should think of the next step in building a larger consortia and biorepositories. And I want to briefly review our experience from the European Epilepsy Brain Bank Consortium, which is a part of the European Reference Network, EpiCare. And we just have finished the first 5-year term, and we are now applying for this for the next 5-year term. There are many colleagues, and some of them are here today. And I just highlight the neurosurgical colleagues in bold and italics, and you see that there is a huge recognition of the neurosurgeons in this European Epilepsy Brain Bank Consortium. And this is the article that we wrote in 2017 about almost 10,000 patients from 36 centers. But just to mention, this still was a very virtual brain bank. This is not that we have really reviewed all the tissues or collected all the blocks and reviewed it. We collected the diagnosis from the centers, although more than half of it were from the Erlangen Institute, as we run for almost now 20 years a German reference network already. So, and these are the results, and this has been already shown by Carl in part, and just to remind you that we have the top 10 diagnoses. I think Carl told you the top 3 are 50%, the top 10 are more than 80%. So despite we have reviewed 10,000 patients, there are only 10 diagnoses to know and to understand and to well recognize, and that will explain more than 80% of all the epilepsy surgery patients. I think this is remarkable. And amongst them, of course, you have a different distribution amongst adults and children. So in adults, the leading diagnosis still is hippocampus sclerosis, and then the low-grade glioneuronal tumors. We have many no lesional cases, so no lesion in terms of histopathologically, not lesional. And then the FCD type 2, the cavernoma, which is also the one that has the latest seizure onset amongst all of them as a category. And then in the children, you have more of the FCD type 2. This is by far the most common, then hippocampus sclerosis, and then the ganglioma, and also the non-lesional. So you see there are similar disease categories and diagnosis, but at the end, these 10 sum up to 80% in children and almost 90% in adults. Yes, and that is just the same as shown here, just in the major disease categories: sclerosis, tumors, malformations. These three come up with 70% here, and then these of the entire cohort. Then we have 1/3 were children, but here you see the outcome. That is the other important thing, that with these huge collaboration, you do not only describe the disease spectrum, but you can also come up with some functional parameters, and that is the outcome over a really huge series of patients. And overall, you see that the children do better, and that is, to my understanding, most time it's true, or is due to the longer disease duration. That many patients are. Let's put it this way: the adults, many of these lesions have their seizure onset in childhood, but then these patients here, they were carried on with drug trials, 1, 2, 3. Some had more than 10 different drugs, and the years came by, and then the decades came by, and then they have here 20 years of disease duration from seizure onset to surgery, and that dramatically decreases the chance of becoming seizure free, and that is different in children. And this is exactly what happened here. So this still is from our New England Journal paper, but the outcome was not really a focus then. So we asked the same group of surgical centers to submit again, and then focus on the outcomes. So we collected surgical outcome at 1, 2, and 5 years after surgery, and also asked whether patients were not only seizure-free but also drug-free. And again, more than 9,000 patients from 37 centers, and you see here an overwhelming result that children do better, and that for tumors and the vascular lesions, more than half of all patients were drug and seizure free. And that is remarkable. I mean, they're cured. And that's exactly the take-home message here. For the adults, they usually go on taking the drugs. They are, more seizure free, but they still continue the drugs. And I think this has different meanings, and I think driving licenses and others are play a role here. But if they would come early on for surgery, they have a good chance, really a very good chance to become seizure-free and drug-free, even up to 5 years, and that is considered a cure, right? And then what is about the outcome over time? So the probability to become seizure-free. I mean, this is a big issue, and the Cleveland Clinic has done a lot of work, and the group of Lara Jehai, she even published a nomogram where you can probably calculate that upfront, and I tell you, the diagnosis, let's say the structural diagnosis, is an important predictor, as is the duration. And you see here, so the disease duration, so from onset to surgery. And you see here that with the duration, the probability to become seizure-free drops significantly, almost 10% per decade. So 1% per year dropping. And there are only very few exceptions. And interestingly, the exception is hippocampal sclerosis, but most others, they drop significantly. So if you wait 40 years, the probability will sink 40% to become seizure-free. And that is not new. There are many papers that have confirmed a similar thing, although this has never been really prospectively shown in a controlled trial. Good. that was my second point. You know, bringing in from the collaborative interdisciplinary group to larger networks, and then also starting to collect tissue in tissue biorepositories to be able to respond to these vast new developments in genetics and biotechnology that points towards evidence or precision-based medicine. And I will give you also an example for that. And you all know about this development in neuro-oncology, and we now have the 5th edition of the Blue Book. I don't know if you have seen the cover yet. This is it. It's out since a month or so. The book is really thick now. I think it doubled in pages, and that's due to the many molecular data that has been added. And for epilepsy surgery, I think we are not there yet, honestly. And I'm happy to discuss your experience with that or your views with that. And one point or one issue of that I want to highlight with my next slides, that this is DNA methylation. DNA methylation has become a success story in neuro-oncology. So we have now the ability to assess the DNA methylation signature from the paraffin tissue for the brain tumors. I think with more than 100 subgroups and subfamilies of brain tumors, but this is not so well established yet for the low-grade epilepsy-associated tumors. I have to say this works very fine for more malignant ones and the more common ones. And it has not yet been shown for any other epilepsy-associated lesions, such as the malformations. And that just changed. So Sami Jabari and Katja Kobo from my lab, they published this beautiful paper using the Illumina EPIC arrays for DNA methylation on a sample set of 320 brain tissues from cortical malformations, and they including all the FCD1s, the 2s, the 3s, hemimeganoencephalies, polymicrogyres, TSC, MOGE, MMCDs, and so forth. And they come up with this fantastic classifier that really looks very similar to the one that David Kappa published on the brain tumors. This is a famous 2018 Nature paper from Heidelberg that is the foundation to the DNA methylation profiling and disease diagnostics. It's very similar working for the MCD. We had to change a lot of things, so it's not the same approach anymore. It's also based on a deep learning algorithm. However, it can work on paraffin tissues. So this is nice to have when you have a large biorepository, and the same holds true obviously for the genetic changes so with the brain tumors that started in the 1990s, 1980s with the first mutations, when P53 was discovered and so forth. And then they are the LOH on chromosome P19Q, and then the MGMT promoter methylation and so forth. And now for the brain malformations, we have a similar success story now with the mTOR pathway genes that we know, like the TSC, the mTOR itself, the DAPDC5, NPRL3, and so forth. So we know that many of these FCD2s carry such mutation, and these are the druggable targets. So we with the tissue at hand, and in the situation where the patient does not get seizure-free, we may have a druggable target at hand and can go for precision medicine. And this is here our recent Lancet Neurology review, where we compared the situation between our malformations and low-grade brain tumors. So it's not only it is so important is when the mutation is acquired. It's a brain somatic mutation, so brain mosaicism. It's not in the blood. It is really just in the affected tissue that you can study, and that defines largely the size, and the gene, the affected gene defines whether it is a tumor or a malformation. So these are here, this is an FCD with the balloon cells and dysmorphic neurons, and then you have a tumor again with abnormal neurons and abnormal glial cells. So it's glioneuronal in nature. That tells you the abnormal gene was acquired during neurodevelopment, probably in the second or third trimester, and then it grows into the cortex and becomes heavily epileptogenic. Good. The last point I want to mention, I hope I have some minutes left. I'm a little bit long now, is that we have also to face new disease entities. That not everything has been discovered yet in the field of epilepsy surgery. The neuropathology diagnosis that I was just mentioning, the top 10 list and so forth. So these are, let's say, scientifically sound and has been confirmed and so on. But in this non-lesional group, probably there are some new entities that we haven't yet discovered. That is shown here, right? So there are a couple of almost 800 non-lesional cases, and maybe there is something in. And I want to show you this case here that truly has an abnormality in the VoxerBased morphometry in the map fusion, less so on the structural MRI. But here it sounds like this could be an FCD type 2 or something. And then this young kid where the epilepsy started at the age of 5 months, then she was 9 years old when we got her. And I think Carl resected the frontal lobe, and we couldn't see this abnormality on the MRI that was seen on the MRI by naked eye. I mean, the gray-white matter boundary looks very sharp, but at the microscopic level there is an abnormality, and it took us some years to believe in this, and we have seen now more than 50 of these cases. And we call them MMCD, so mild malformation of cortical development with proliferative oligodendroglial hyperplasia in frontal lobe epilepsy. That was the original paper, but now we skip frontal lobe because it was discovered already in temporal lobe, parietal, and also occipital. So we call it just in epilepsy MOGE. So this is here the HNE, and you see here the gray-white matter boundary. On top is the layer 6. These are the neurons, and then you have the boundary here. And I do some higher magnifications of that deep white matter here. That these blue spots, these are the oligodendrocytes, and I hope you can appreciate the cell number. And on top is the same magnification. You have a double, triple number of oligodendroglial cells. And first we were very scared that this is a tumor, and we checked all the tumor genes at that time. And now we have even a follow-up period of more than 10 or 15 years. And I tell you, it's never regrown. This is not a tumor. This is really an abnormal hyperplasia where these glial cells just proliferate. And we don't know why. It makes a signal abnormality at the gray-white matter junction, and it usually occurs in children, frontal lobe, very early onset, and it's a large lesion, I have to say. And here, till Hartlieb from the Vogtoroyd Center, he discovered also the MRI signature and described it very well. It is here this abnormality at the gray-white matter boundary, and that resolves over the years. So this is a younger patient, and so the abnormality is differently visible in older patients when the patient grow older. Irene Wong from the Cleveland Clinic has also attempt to identify these MOGA on 7 Tesla. I think it's well visible. Also here with the map junction. And interestingly, and this makes now really the difference, now we discovered a genetic mutation. Again, brain mosaicism, so it's not in the blood, it is in the tissue, and it affects the SLC35A2 galactose transporter gene. It's in the Golgi apparatus here, and it transfers the galactose. So it's a sugar pathway, and we have no idea yet why this is why this situation becomes so epileptogenic. But there are many things going on with these galactosylation, also in terms of when the myelin is built and so forth, and we have to look into these animal models. They are not yet that, but roughly half, 50% of all our patients with the with the diagnosis of MOGE carry these mutations, and it's a different pathway, right? And it's druggable. You can add a diet to this patient that substitutes the galactose, and that is possible. It has been published, and now some centers are trying that. So this is the interest here. We discover new patterns, and then we find the genetic abnormality, and then we may have a new drug target. And so this is the first one that is really outside the mTOR pathway, and it is not the FCD type 2, right? Although some look very similar, some lesions look similar on the MRI. They are not. They are completely different etiologies. They have different genes, and hopefully we find a very precise treatment for these entities. Okay, so that's the end of my talk, and I hope I had highlighted why I think the very close cooperation between the neurosurgeon and neuropathology is important. It will help you and us to understand the situation, the epileptic condition, and also find new biomarkers, right? That you can use upfront, not at the end when everything is done. No, when we receive our diagnosis, now that you recognize the lesion before, and that we discover a new biomarker. So the same holds true here for the biorepositories. So I haven't told you that now it might be also possible to identify the brain somatic mosaicism in CSF samples. The exception here is that you have to know what you're looking for, because of the amount of cell-free DNA is very, very little. However, it is working this way, and we get new biomarkers at the end of the day, and the same is with maybe some more diseases that we haven't yet found or yet scientifically described. Just to highlight that we have this amazing summer school for neuropathology and epilepsy surgery. So it's less an epilepsy surgery course; it's more a neuropathology course, but it circles around the epileptic condition and epilepsy surgery strategies. It will hopefully be in person this year in September in Erlangen. It's the 11th course already. And also, it's my pleasure to acknowledge that the International League Against Epilepsy has set up a beautiful e-learning platform with case courses, and so all different levels of proficiency, from beginners to experts, that you may be interested to join. And the platform is just in rebuild, so it will open next week again. And these are just some of my long-term cooperators, and thank you so much for your attention. I'm happy to take questions.
So can I ask a question? So I appreciate Carl and Ingmar, of course, for the talk. It was wonderful. So thank you so much. My question is specifically for Ingmar. We, in cases with non-lesional epilepsy, we end up doing large resections. And many of those cases, the pathology is perhaps a small end of the sulcus for cortical dysplasia that cannot see or was missed by the pre-surgical studies. And then we give to the pathologist a big piece of tissue, and most likely this depth of the sulcus cortical dysplasia will be missed because of the amount of tissue. Normally we perform larger resections for non-lesional epilepsies. So especially for frontal lobe cases. So I wonder, from a pathologist point of view, what are your recommendations in how we can better access those non-lesional large resections? How can we communicate better with our pathologists so we can perhaps pick up those small changes that we cannot pick up because there are such a large resection? I just want to know what's your perspective about that, Ingmar.
Thank you, George. Yeah, you're right. I think this is exactly the situation where we need to talk, and hopefully even before you start the surgery, that the pathology is in the loop. And yes, when you have a large resection, you may end up easily with 30, 40 blocks of paraffin tissue. And then the pathology colleague has to review all of them, and it's not going to work. I tell you, this is why we miss it. So the best situation here is, first of all, we have the orientation. We know where is anterior, where's posterior, where's lateral, where's dorsal, and then you can do any kind of marking on the specimen, like ink, or again, the staples that you just add superficially, where that you think this is what neuronavigation or all the functional tests have shown, and that the colleague who is doing the tissue processing has a clue where they should focus their attention on. I mean, nevertheless, it will be a search of the needle in the haystack at the end of the day. If you have a very small bottom of sulcus, FCD2, it may be still, it can be small as a millimeter small. We can miss it. I mean, this happens, but it should not happen, right? And we should take all measures to avoid that. And the epileptologist took so much time to characterize it well, so that we, from our side, the neuropathology side, should add to this approach, and with considerable time efforts and technology efforts to make it visible. Yeah. So if everybody knows what they have to look for, it's much easier, right?
Mario has raised a hand. Please, Mario, I will allow you to talk.
Thank you, Bertil. I see the problem a bit different than Jorge just mentioned before, Ingmar. There are cases where you have only non-lesional epilepsy with different types of seizures. And for those cases, large resections are needed. I think, for those very small lesions that we are not seeing on the MRI preoperatively, and we don't have enough data from the neurophysiological standpoint, that might work. But I think in many instances, large resections are needed. Just look at the results you have there. You have at the end of the day, they're very low, the results for non-lesional epilepsy, not only in children, but in adults. So the strategy will be a bit more complicated than this. Then I think that in many cases, again, I will say that large resections are needed, and they're needed because of the result we are having through the years. And for those of us who have been in the ball game for a long time, well, this is very important because, you know, it's a frustration for the team and also for the family and children. Thank you.
Yes, Mario, thank you. I agree. I mean, if you have a complicated situation with different seizure types and you just know that the whole thing is somehow involved, I mean, this is also an important information that the neuropathologists need to know. So in that situation, I would myself, you know, we would probably make a very systematic sampling. We cannot look into every millimeter, but we you know, we take 5 millimeter slabs and would probably take 15, 20 samples over the whole resection, and then start discussing and see whether we find some of our common suspects, and then come back to you and sit on the table, post-surgical case discussion series. We have that now online. Yeah, and then see if we missed something, if whatever we see, if this is only gliosis, or are there, you know, some mild malformations, these heterotopic neurons, or these Mogge cases. I mean, if that makes sense, and then we probably could go also one step further into the molecular diagnostics. However, that costs money, that takes a lot of time. So you have to consider at least 4 weeks or so, or even more, to get back a panel sequencing and what many colleagues of you do, and I'm very thankful for that you also ask for a second look. You know, if your local neuropathology does not resolve that, ask them to send the specimen over here for us to Erlangen. You know, we are now on behalf of the European Reference Network. We are, I think we are well suited to deal with these numbers of cases. We do almost 300 a year now, and yeah, and this is how we should work together. Thank you.
And then I have a question from Dirk van Roost. And please, Dirk, I have allowed you to speak, so please unmute your mic and put your question directly.
I have the same opinion than Mario has, and to be honest, I find it very frustrating when we have an MRI negative epilepsy and know even the lobe, and we put in several electrodes, and after that we are still not knowing where the epilepsy comes from. And so it consequently ends in a large resection, but I'm always afraid that the neuropathologist doesn't find anything. And so before we are looking at the MRIs for hours, but we can't localize it. This makes me very angry and frustrated.
I can just agree, Carl. And one of the worst things you can get from the pathologist is gliosis or unspecific, because then you know that this patient will not become seizure-free. Are you with us, Dirk van Roost? You can put your question now.
I have a question to Ingmar Blumke. I noticed that in the case reported, I think it was of a Mogge case, that almost a whole frontal lobe had been resected, while the lesion, which was visible on the imaging, was not so obvious in the first place and rather small. Now, I imagine it might be difficult for Ingmar Blumke on the top of the food chain to retrieve all the reasons of the neurosurgeon and the neurologist. That's my question.
Well, hi, Dirk. I mean, we know us from Bonn, right?
Yes.
That was 25 years ago. Oh, time, right. Time has gone. No, Dirk, thank you for the question. I agree. You have paid good attention to that. The MAP fusion lesion was rather small, and the epileptologist and also the neurosurgeon, they expected an FCD type 2, but all of the EEG pattern was more widespread. So that was pretty clear from the pre-surgical monitoring and evaluation that this patient would not would not benefit from a very local resection. So they did a large resection. And our experience with MOGA is that this disease is rather widespread. And our very first publication summarizing, I think, 17 or so of our patients, the post-surgical outcome was very bad. It was only one third, 33% of patients were seizure-free. And that increased to almost, I think, more than 50 or 60% now with the larger resections. So now that our colleagues know better, and that they know all the pitfalls, and if that is, has, or that the epilepsy shares features of MOGA, that they have to do a larger resection per se. And many of the samples read non-lesional in the past, and I think still some centers would probably not recognize it well on the pathology point of view. There are some other diagnoses such as FCD1 and MMCD that are in the basket, and some centers or some pathology colleagues would call it rather MMCD or FCD1. But we also had this other paper where we reviewed all the SLC35A2 positive cases that have been labeled MMCD and FCD1 and and was blinded, and we could establish the diagnosis of MOGA in all of them. So that needs just a little bit of workup and more immunohistochemistry and other antibodies, and then you finally get that diagnosis. Okay, so the take-home message is here: MOGA requires a larger resection field than FCD2.
Thank you, Igmar, for the very useful remarks.
I have got a question from Erasmo Passaro, and please, I think I have allowed you to talk, so please put your question directly.
Sure. So, yeah, my comment, I'm an epileptologist at Johns Hopkins All Children's in Bayfront in St. Petersburg, Florida. And I agree, the MRI negative cases are very challenging and quite humbling. Obviously, we don't implant somebody unless we have a good hypothesis using PET, co-register MRI, Dospect, and MEG. And then also semiology to map the network, which is key, as you all well know. And then another point is the use of remote ORs that have not occurred in years can sometimes localize. But actually, my point is more of a surgical one in the context of that network, is that I think it's imperative to implant the electrodes to straddle the sulci, because that's, I think, where the seizures propagate and most often originate. And that if one doesn't straddle the sulci using, because obviously the SEEG electrodes have limited sampling, it's only 0.8 millimeters in diameter, but that you have to increase the chance that you could potentially find that network by implanting the electrodes within the sulcus. So let's say it's the superior temporal sulcus, or looking at the cingulate, looking at the motor cingulate. I mean, if you don't straddle the sulcus, one will see a propagated pattern and not be able to see. I mean, that's not the entire solution to these MRI negative cases since they're so complicated, but I think that increases the yield.
Please, Igmar.
Excuse me?
I don't know if Guy McCann or Jorge is on. I'd be interested in their thoughts and comments.
Would you, Igmar or Carl, respond to Erasmus?
Well, I understand. Yeah. Well, I think Erasmus, I think you addressed this question rather to Guy and Jorge, right? And Carl, yeah. So please forward the surgeons here.
Maybe I can say a few things. We always try that, but the problem is that we also sometimes are feared if there are larger vessels in the sulci, so that we want to avoid also hemorrhages. Maybe this is a point which also should be considered.
I have a general comment, and that is to you, Ingmar, because we were both on that paper, and you and I discussed, and also Carl discussed a lot about there is a contradiction between the pathologist urge for large specimens and the function of the patient, and to preserve the functions of the patient. So of course there is a sort of contradiction between taking too much and only taking what is really needed. And I think both Carl and Ingmar could sort of comment on that, please.
Yeah, maybe if I start, we always try to include functional information in our surgeries. Some are also doing awake surgeries, but we try to push the resection very near to eloquent areas to avoid this problem of incomplete resections. And we also more or less accept temporarily neurological deficits if it is included in the informed consent for such cases to avoid to get the so-called double losers.
Yeah, thank you. And I think the double loser problem is really, really important. Please, Ingmar, if you have some further comments.
Well, not really. You see, we don't see any functional biomarkers in our specimen. That's impossible, right? We can tell you if there is one of these accepted gross lesions from the spectrum of tumors, of FCD2s, and so forth. And some of them could be, very, very small and diffuse. And widespread, so it's not easy to detect them. But what I think will come up in the future is more of a genetic-based diagnostic tool. And I showed you what can happen already if you do panel sequencing and so forth. However, it's very expensive and takes long. But with the DNA methylation, that's much quicker. That goes rather quick, and costs only 200 to 300 euros. And once we have large enough samples covering the whole spectrum, it's likely that these cases may match to one or the other subgroup. And that gives us more confidence, and I think that could be very helpful. And then we'll have to see whether or not they are losers or winners of that situation.
Okay, thank you so much, Ingmar. So far, I don't have any further questions in my chat. Do anyone of the panelists have any questions or remarks? So please.
May I join, Berto?
Yes, sure. You have raised your hand, and also I see that Guy has raised.
Would you like to go first, Guy?
Oh, go ahead, Arthur, please. You were first.
Okay. So I'm so glad you mentioned MOGI, Ingmar, because somehow we got a bunch of them over the last months, and some of them are outside the frontal lobe, and some of them has pretty normal high-resolution MRIs. My question, I have two questions. One is specific and the other is more generic. Would you please elaborate on what would be the role of oligodendroglia in epileptogenesis? Because it's easy to imagine the role of neurons, but what would be the role of oligodendroglia in epileptogenesis? And how would you classify these patients? Would this be type 3 in your classification or else? And the second more generic question would be, there is a kind of movement towards getting rid of HE in pathology evaluation, especially in the tumor world. Are we gonna get rid of HE in epilepsy pathology too?
Thank you so much. Many questions. Let me see if I get them straight. So the first.
Don't worry. I will call you back if you forget one.
I take it the other way. So there are some straightforward to answer. So the MOGA classification is, it will be included into the update of the FCD classification from the International League. We just concluded the 4 years work of a task force that were asked to update this 2011 FCD classification, and it has just been submitted. It's now under peer review, and the short answer is that MMCD and MOGA will be included into that. So that will be a single disease entity in the spectrum of the overall, FCD spectrum. And second, very easy to answer.
This means type 1, 2, 3.
No, it's an independent. It's a new yeah, it is white matter based diseases. So you see, we have the FCDs are rather cortical, right? And then we have the MMCD and the MOGA, where the pathology is rather located in the white matter. And that is probably your first question. We don't know why that is so. We just know that the oligodendrocyte has a lot of functional a lot of interaction with not only with the axon, but also with the neuron itself. It impinges the myelin sheath. It supports, but it has also some functional connection or some networking connection. So we don't know that yet. We need the appropriate animal models, and we have studied a little bit further. It's not a myelination phenotype. It's really an oligodendroglial phenotype, and the myelination is kept up. So we know in the young kids the myelination is deficient here. We have really gaps of myelin, but that is caught up. So when the patients grow older, the myelination comes back, and this is why it's difficult to see them on MRI when they grown older. So it's like, the earlier the better for the MRI detection. And then the last question was why we still use H&E. The interesting point here is that with the digital pathology, H&E becomes a quite an interesting stain for deep learning classifier algorithms. When we train the computer to learn what is FCD type 1A and 1B and 2A and 2B and 3A and 3B and whatever, and all of this, that works pretty well on H&E because there are so much information in between, and honestly, it is very cheap. H&E is still very cheap, so very cost efficient, and if we can support the diagnosis with a platform that is open access and that relies on our deep learning diagnosis of you just upload your whole slide imaging, your digital slide, and then you receive within 5 to 10 minutes a classifier from this deep learning algorithm. I think that's the future, and then we don't need to get rid of H&E. We rather can make it more cost efficient.
Thank you.
I hope that answered your questions.
Thank you so much.
And then Guy, you have raised your hand, please.
I have a question for both Ingmar and for Carl about related aspects of a topic, which is sometimes we see, and I think we are seeing even more of it, where you have an isolated amygdala fullness. And so you see amygdala fullness on FLAIR or T2, it's subtle, it's real, and doesn't change over time. And particularly if you have somebody who it's their dominant amygdala, obviously you're worried about their adjoining neuropsychological function. And so my two questions are for Ingmar. Do you think that there's a pathology that we have not yet fully defined of amygdala fullness in epilepsy? And for Carl, if you have a dominant amygdala that you think is responsible for someone's epilepsy who has normal neuropsychological function, what is your preferred surgical approach to remove that amygdala? And what do you think is the risk to the patient?
So please, perhaps Ingmar first and then Carl.
Yeah, thank you, Guy. So what you're asking is this hyper intense signal alteration of the amygdala. Is that what you're saying?
Yeah, exactly. When the amygdala is hyper intense and also
yes,
a little bit full, and you're suspecting maybe there's a glioma in there.
Yes, I know. This is interesting. I mean, this is observed often and then also resected. And I agree that the pathology read here is usually negative. What we always do here is we look very careful for inflammatory cells. And that might be overlooked if you just go on H&E without the proper immunostains, that you miss some T lymphocytes or activated microglia. So my take would be that in particular in a patient with late onset first seizure and this condition, that this might be an inflammatory cause that may not be there anymore, but it has been, and may be lucky and find something. So in terms of maybe a limbic encephalitis or something, the worst case scenario would be that we miss a paraneoplastic syndrome, right? I mean that's something where we're always scared, and that's why we do it. But I have to say, in many cases we don't see that. So this reads negative, but we always have, and I would ask every colleague to do it, to follow that rule to rule out the inflammatory course. Now, because when you miss a limbic encephalitis and paraneoplastic syndrome, then we do harm to our patients.
Please, Carl, you have any comments?
I think I have operated on 2 or 3 such cases, but they were non-dominant, and I always took the pole additionally.
So I guess I would ask the question for any of the other surgeons on the panel, their thoughts of how to best operate on the dominant amygdala if you're trying to spare all the rest of the mesial temporal structures.
I think that's an extremely difficult question. I think it's extremely important to listen to your neuropsychologists and to your neurologists, because it's so there is such a great risk that the patient will become a double loser. It's very, very difficult, these cases.
One option in these cases would be to do a staged approach. So go for a more selective resection if patient continues to have seizures, then do a larger resection potentially.
Yeah.
But so Christian, the selective resection there, would you go transsylvian to get to the amygdala and not go through any temporal lobe, or would you make a window through the temporal pole?
I think I would go for a window through the temporal pole.
I think it doesn't make so much difference if you make a selective amygdala hippocampectomy or through the temporal pole, because still you are deafferentating lots of fibers doing a selective amygdala hippocampectomy. So I think that doesn't make so much sense. So I agree with Christian. I will do it.
But what about Bertel?
Sorry?
I was just saying, what about a selective amygdala removal, preserving the hippocampus and parahippocampal gyri?
Yeah, this is possible. I think this is. I've done this a few times.
Yeah.
It is. This was my standard procedure in such cases.
Please, Rasmus, you put another comment.
Yeah, so I've certainly seen patients with that same amygdala enlargement, and then pathology invariably comes back, negative. I think one of the things as epileptologists, the problem is we conflate temporal pole, amygdala, and hippocampus as all one, and I think that's true for regular hippocampal sclerosis epilepsy. But I think there are subgroups of patients who have purely temporal pole epilepsy or temporal pole amygdalar epilepsy, and if you do SEEG, the seizures actually propagate to the hippocampus but don't begin there. But anyway, my question is, and this is, I'm curious to hear from the surgeons, if you do a resection of removing the pole, and I believe if you take the amygdala out, you probably need to take the pole out too, but that, and of course, if you want to preserve verbal memories, the dominant side, you want to stay away from the entorhinal cortex, because otherwise you'll disconnect the hippocampus. So surgically, what does a surgeon do to take out the pole, the amygdala, but at the same time, cautiously not affect the entorhinal cortex?
That's a great question. May I first ask you, Carl, to make some comments?
I think maybe this from the functional side, it's not easy.
No,
Yeah.
it's not this. Guy, what do you say?
There are large series of corticoamygdalotomies in the literature, one coming from the MRI and the other coming from England. So it's not going to be a major difference. There is difference in outcome though, and both series from England and the MRI showed that compared to including the hippocampus in the resection, the results are worse. But from a technical point of view, I don't think it's a major.
But I think to address Erasmus's question a little bit, I mean, I think for all of us as surgeons, again, it depends. If you're coming from Transylvian, you can get to the amygdala directly without going through any brain, but then you don't have the ventricular anatomy to guide you. Whereas if you're going transtemporal into the hip, into the temporal horn, once you're in the temporal horn, you can see the amygdala, you can see the hippocampal head, and you know where you're trying to resect and not detach. And so you can completely preserve the hippocampus and all the adjoining parahippocampal gyrus and just remove the amount of amygdala you want from in the ventricle surgically. And so that's why I was wondering for the surgeons, which of those they prefer and whether there's a neuropsychological outcome difference in not going through the temporal dominant pole.
Thank you, Guy.
And I'm asking that particularly because I have an interest, because I've got 2 or 3 cases sitting around right now where we're deciding what to do, where we've gone through SEEG, and it's like you say, Erasmus, their seizures are really starting in the amygdala and rapidly spreading to the hippocampus, but it's their dominant hippocampus, highly functional, and what's the best surgical approach? And then also, as I was saying to Ingmar, what's the pathology in these cases? Because it's not tumor most of the time.
I think that is one of the key questions, Guy, really. It's very important not to take away functional hippocampus, but I think my personal view is that it's not a general, very simple reply to that. Anyone else from the surgeons having a comment on that? I would appreciate that.
Mario raised his hand still.
Okay, please, Mario.
Thank you, Bertil. Well, I have probably more than a dozen of these amygdalectomies. And I think it's a very straightforward surgery. I mean, already Arthur already mentioned it. There is a paper back-to-back with of the MRI series, the one from Feindel doing a pure amygdalectomy and the one from Tetras-Musin doing amygdalohippocambectomy with amygdalohippocambectomy with pretty much the same results. So I don't think it's a complicated technical business to go either through the Transylvian or go basal, to do a selective amygdalectomy. And by the way, of these cases I don't recall to have a major complication from the psychological standpoint. The last case that I had is a 46-year-old man that had epilepsy from temporal lobe epilepsy from when he was 19, and he was studied at the MRI. He was studied at San Diego, and they didn't perform surgery. And I operated this guy because he developed a focal encephalitis of the amygdala that Inma Blunke review, and the patient is being operated 4 months ago, and he's seizure-free and with no any psychological complication. And this is the last one that I remember. Thank you.
Thank you so much, Mario, for that important comment. Sometimes we have done that sometimes in Göteborg. I think it's important that you may take the discussion with the patient. If you have a patient in the 20s having a dominant epilepsy and sort of in between handling the epilepsy and going for higher studies, then you could sometimes, and we have done that, postpone surgery for 3 or 4 years until examinations have been done, and then you could operate. So I think we should all be aware of that possibility to have that communication with the patient. Just a comment from me, please. Any other comments from the panelists or from the audience? Otherwise, I think we are very close to the end of this very, very interesting session.
And I will open the post-webinar meeting.
Yeah, thank you. So thank you so much, everyone, for joining this meeting, and look forward to our next meeting. So thank you and bye.
Thank you very much, Bertil. Thank you.
Thank you,
Carl.
Carl.
Thank you, Carl. It was great.
Thank you,
It
Ingmar.
was so
Bye-bye.
nice. It was so nice to have both you, Carl, and Ingmar on the same session, because you have been working together so many years. So thank you so
Lovely.
much,
Yeah,
everyone.
we don't meet so often in the last few
That's right.
months.
No, but you have a great history together. So thank you, everyone, and see you next
Thank
time.
you.
Thank
Bye
you.
bye.
Thank you.
Bye.